Janssen from Geneva on cardiorespiratory exercise test. Please, Jean-Paul.
So good morning to all of you, and thank you for the invitation for giving this talk on cardiopulmonary exercise testing. Actually, this talk is more oriented towards the younger members of the audience, but I'll let you define who is young and who is less young. Always a very difficult question. So the cardiopulmonary exercise testing is actually, as you know, a wonderful test because it explores all aspects of the exercise physiology. It starts with exploring the adaptation of the mechanics of the pulmonary system to the increase in effort. Then, of course, indirectly, we will be exploring also the transport of the oxygen through the cardiac function. And finally, we get an idea of the muscular capacity in terms of extraction of oxygen, and well, it is a test which can be used, of course, to detect pathology at the level of the mitochondria. So what are the classical indications for cardiopulmonary exercise testing? Well, unexplained dyspnea, preoperative assessment, pre-rehabilitation assessment. This is now an increasing indication since pulmonary rehabilitation is widely accepted as a type A evidenced treatment for COPD and most chronic respiratory disorders. Suspicion of pulmonary vascular disorders is a good indication. We will see this later on. Evaluation and follow-up of interstitial lung diseases. Of course, it's not a diagnostic test, but it would be helpful to see the follow-up of these patients. And then functional disorders. We will spend a few minutes on this. Documenting dynamic hyperinflation, which was mentioned by Michael Tam, and finally, suspicion of muscular disorders. Exertional asthma actually is less and less explored this way since we have other simpler tests to make this diagnosis. The usual protocol is a rapidly incremental increasing test by steps which can be 10, 20, or 40 watts depending on the level of training of the subject. And so what we expect to see is the following parameters. You have the heart rate, you have the oxygen consumption, the CO2 production. Here is the warm-up phase, sorry about that. And now we see what happens when the exercise starts. We have an increase in heart rate, in minute ventilation, in CO2 production, in oxygen consumption, and then a critical level, which is called the anaerobic threshold, where the production of CO2 exceeds the oxygen consumption. And as we see here, we actually have changes in ventilation which respond to a very specific increase in slope. So this is the basic slope for the beginning of the effort. Then after the increase in production of CO2 related to the anaerobic threshold and the fact that lactic acid is produced, there's an increase in the slope, which is the first ventilatory threshold also, and then a second increase, which will be related to the drop in pH, so to increasing acidemia. Finally, the peak VO2 or maximal VO2, as we will see, is very important in clinical practice. Just to remind us what variables we're going to be looking at, well, one of them is the oxygen consumption, obviously, which is very important because it is directly related to cardiac function and to the capacity of muscles to extract oxygen. So taking the oxygen consumption and dividing it by the heart rate, we get the oxygen pulse. And this is actually, for the pulmonologist, a cheap way of having an evaluation of the left ventricular ejection volume. So it's a sort of cheap echocardiography, much easier to read for the pulmonologist than the real echocardiography. And then when we look at the VO2 max, I think it's very important to have in mind the type of values that we're expecting. So many of you are pulmonologists, and you will very rarely be seeing patients with VO2 max values of 60 or 70. It's only those of you who are involved in testing people who have a high physical activity which will see this type of values. For patients who have sedentary type of lives, then as you see, the VO2 values values will be mainly between 30 and 40. And values lower are then clearly abnormal when you compare them to a general population. I think it's important to have these figures in mind and just not to look at basically the percent of predicted. Here you see also the evolution of the VO2 max as a function of age. And of course, there's a linear decrease in VO2 max in women and in men. You see here the situation for men and women around the age of 40. And as mentioned earlier, these expected values are somewhere between 35 and 40 milliliters per minute per kilo for people who have a normal activity. And then before we go into looking at a few tests, we have to have a few basic formulas in mind. First of all, of course, we're going to evaluate the respiratory function and determine if we've gone to the maximum of the respiratory mechanics. And for this, we have to estimate the maximal predicted ventilation. There are several formulas, but one of the easiest formulas is just to take the FEV1 and to multiply it by 35. Same thing for the maximal heart rate predicted, it's 220 minus the age. And then when we have a patient who is going to start an exercise test, we also have to be reasonably sure that he has been resting enough before he started the test. And for this, we have to look at his heart rate, at his oxygen consumption, his CO2 production, the ratio of CO2 to oxygen production, and the minute ventilation. So these values will tell us if we have a patient who has really been resting before the test or if he has already done some type of exercise. When we look at the results of the effort test that we will see in a few minutes, then we're going to be looking at a certain number of parameters. First of all, we're going to take a look at what happens at rest and look at the ventilatory mode. This is very important because many of our patients actually may have dyspnea just related to their ventilatory mode and not necessarily to an underlying respiratory or cardiac pathology. We will also look, of course, at their heart rate, blood pressure, and arterial blood gases. And then during exertion, there are a certain number of systematic approaches which will first explore ventilatory mode. How do I increase my minute ventilation? Do I reach my maximal ventilatory capacity? And how do my respiratory equivalents progress? The respiratory equivalent is the ratio of total ventilation on oxygen consumption, or for CO2, the ratio on total ventilation on CO2 production. Then we will look at the metabolism, and one important component is to try and evaluate what we call the anaerobic threshold. And finally, arterial blood gases, of course, are mandatory to be able to get all the information of the test. Is there hypoxemia during exertion? Is there an increase in the gradient between alveolar and arterial oxygen? Is there hyper or hypoventilation? And is there an increase in physiological dead space? So let's take a look at a normal test. This test was performed a few years ago by a medical student who came to do a clerkship in our ward. He was 30 years old, normal pulmonary function test, used to play basketball quite regularly. And so this is what we got at rest. You see here his ventilatory mode, which is normal. You might note, since you saw the figures earlier, that probably he was not actually quite resting when he started his test. And indeed, he had come a bit quickly running up the stairs before he started his test. These are the blood gases. This is the estimated physiological dead space and the heart rate. And so we look first of all at how the test progresses in terms of his ventilatory mode. You see here that the respiratory rate increases rather late. This is the increase in the tidal volume, which reaches about 60% of the vital capacity, which is normal. Here you see the VCO2 on VO2 ratio, which increases and passes above 100% just at 200 watts. And here you see the gas exchange. We have a little bit of a decrease in PO2 here, which is probably related to the fact that we use capillary blood when we do arterial blood gases in these patients. And you see also the decrease in base excess in bicarbonate and the acidemia. And then finally here you have the arterial blood gases with a normal evolution of the difference between alveolar and arterial oxygen. The dead space and the ratio of dead space on tidal volume here decreases quite nicely, which is the physiological evolution of this parameter. Now, if we look at all these parameters together, what we see is someone who did a quite honest performance of 200 watts, who was close to his maximal heart rate, and who reached his anaerobic threshold close to the end of the effort without any abnormality of his blood gases or of his physiological dead space. Here you see actually how one tries to estimate the anaerobic threshold. This is called the V-slope method. You see here the VCO2 on the y-axis and the VO2 on the x-axis. And once the ratio of VCO2 on VO2 increases above 1, there is a change in slope, an increase in slope, which is related to the increased production of lactic acid by the muscular cells during the physical activity. And you see here how the ventilatory equivalent for oxygen will continue increasing while the ratio of ventilation to VCO2 will remain stable for the initial phase after this threshold and then increase because of the drop in pH. Other thing that we have to look at is how the ventilatory mode adapts in physiological situations. And as you see, what we do all normally is to increase our tidal volume to about 60% of the vital capacity, and the increase in respiratory rate comes actually quite late. So let's just take a look at a few situations to try and document what type of pattern we can get in these three different conditions. First of all, this is the test of a young female subject, aged 30 years old, who had an unexplained dyspnea when performing very modest exercises, which came very progressively. You see here our pulmonary function tests, which are absolutely normal. There's no airway obstruction. There's no restriction. She had a normal body weight. And so let's take a look at her test. The first thing we see is that the maximal effort was 120 watts, which is probably not far from what is predicted, but it's still rather low for a 30-year-old female. Then we see here that the ventilatory mode increased in a physiological fashion. We see that her VO2 max, when she reaches the end of the effort, was below 30, around 27, which is low in terms of what we expect from, once again, a 30-year-old woman. The arterial blood gases here are absolutely normal, but with a very early drop in pH and drop in base excess. And then here you see the gradient for oxygen, which is normal, and the evolution of the physiological dead space, which is also absolutely normal. So how do we interpret this type of test? Well, this is what we see in major deconditioning or in early cardiac disease. Although this patient was 30 years old, there was a very low or a rather low level of performance, a very early anaerobic threshold, a low oxygen pulse, a low VO2 max, without any signs of pulmonary or pulmonary disease or pulmonary vascular disease. So this is the type of patient we would refer for echocardiography or cardiac evaluation. This is another young woman who had also a very important exertional dyspnea, normal pulmonary function tests, normal chest X-ray, and here you see her ventilatory mode. As you can see, the situation is quite different. She is already very tachypneic just when she's resting with a very high respiratory rate, very low tidal volume, and you see that she increases her ventilation mainly by increasing her respiratory rate. So this is a very inefficient way of ventilating, and this is by itself source of dyspnea. Then when we look at her performance in terms of metabolism, we see that she reaches VO2 max of 32 milliliters per minute per kilo, which is acceptable, but within the lower range of the normal values. We see here that she also has a very early drop in pH. We see that she managed to perform 80 watts in terms of maximal effort, which is really quite minimal for a young woman. And we see that the blood gases are absolutely normal with a perfectly normal evolution of the VD on VT ratio. Finally, the test was clearly maximal in terms of cardiac function. So this test was interpreted as major deconditioning and abnormal ventilatory mode. This patient, because of her ventilatory mode, had virtually stopped performing any kind of physical exercise and reached a situation of major deconditioning with a low level of performance, a low AT, a slightly decreased oxygen pulse, low VO2 max, and a high respiratory rate and low tidal volume. So the functional disorders that we've just seen are most often characterized by hyperventilation, by high equivalence for oxygen and CO2, by low performance, and also the maximal ventilatory capacity is often reached just because of the ventilatory mode and the hyperventilation, and actually the anaerobic threshold may not be reached just because of the abnormality in the ventilatory mode. Now, what do we see when we have a situation such as cardiopulmonary testing in pulmonary vascular disease? Here we have a rather typical signature. As you know, these patients normally do not have any abnormality of their pulmonary function test apart from the CO transfer. So here we have the story of a male subject aged 60 years of age when he performed the test. He had actually just flown in from the US. He came to visit our boss at that time. He was a very fit person performing regular physical activity, jogging, swimming. And so these are his pulmonary function tests with a maximal estimated ventilation of 184 liters, a normal chest X-ray. And so here is how he adapts to the effort. So the first thing we see is that for somebody who is supposed to be really very fit, 120 watts is not that much, but we see that he adapts perfectly physiologically his ventilatory mode. We see that he seems to pass his anaerobic threshold rather early with or he hyperventilates with a VCO2 VO2 ratio which is rather high, and then surprisingly we see a drop in oxygen and an increase in the alveolar arterial gradient for oxygen, which was unexpected, and we see also the drop in pH here. And finally, although the VD on VT ratio decreases, when you look at the calculated value of the physiological dead space, you see that we get very high values here. And the fact that the ratio is normal is explained by this very high tidal volume that he has. So actually this test was virtually diagnostic of pulmonary vascular disease, and in fact this man was proven to have a pulmonary embolism, which was related to his recent trip. So I'm not at all suggesting that this is how we should diagnose pulmonary embolism, but this is at least how the test appeared shortly after probably the event which caused his embolism. So pulmonary vascular disease will show normally hyperventilation, increase in respiratory equivalence, increased dyspnea, decreased VO2 max, and blunted or absence of decrease in the VD on VT ratio, decrease in oxygen, and increase in the oxygen gradient. So these are all rather highly suggestive of pulmonary vascular disease in patients who have normal pulmonary function tests. Finally, just a few words about COPD. At rest, of course, the test is non-specific. Basically, according to the severity of the disease, we will have probably slight hypoxemia with an increase in the gradient for oxygen. But then during exertion, what we will see is a change in the progression of ventilation with a low tidal volume and a high respiratory rate and a decrease in the respiratory reserve. These subjects will reach quite quickly their maximal estimated ventilatory capacity. they will have a decreased VO2 max, a decreased oxygen level, and the CO2 may be normal or even increased if they reach their ventilatory limitation. And they may quite often not reach their anaerobic threshold just because they are limited very quickly by their mechanical capacities. In these patients, because there is also an increase in the physiological dead space, there will be a blunted or absence in decrease of the VD on VT ratio, which could be quite similar to what we would see in pulmonary vascular disease. So just because of time constraints, I will pass on to these two last slides. This is so what we see in COPD. You see that during the exertion, dyspnea increases much faster than the normal subjects. You see here that the subject will reach very quickly his maximal ventilatory capacity, which is, as we said earlier, 35 times his FEV1. His oxygen pulse will be underestimated because he will not necessarily reach his maximal cardiac capacity. And we see here the VD-VT ratio, which can remain quite high for the reasons that we mentioned. So through these different tests, what we can have is a sort of suggestive pattern for all the patients that we see and that we put on a bicycle for testing. And there are a certain number of constellations which would be suggestive of COPD, of pulmonary vascular disease, of deconditioning, of heart failure, with the presence or not of fall in saturation at peak exercise. And in this way, this test is quite suggestive and can be sometimes diagnostic of at least one type of disease. So just to conclude, cardiopulmonary exercise testing is a very elegant and simple physiological approach to unexplained dyspnea. Most diseases, chronic diseases, have recognizable patterns on exercise testing, and today it's especially useful for preoperative and pre-rehab assessment, as well as for exploring functional disorders, such as the two tests we described earlier. So I thank you for your attention, and I'm open to your questions.